Today on Vital Insights.
And so to me, I think about these reimbursement codes as a way to push the boat off the dock. So this is CMS giving us a push in the right direction. But eventually we're going to look at these things and say, if what we're really able to do is bend the cost curve because we're intervening earlier and we're preventing the really expensive side of chronic care.
Welcome to an episode of Vital Insights, a podcast series focused on thought leaders and healthcare providers who are working to transform the way we care for patients, now and in the future. Virtual care or in-home care for patients inherently makes sense. We all know that. We know no one heals in a hospital. Patients need to go home for that. We also know it's too expensive to take care of chronic condition patients in traditional brick-and-mortar healthcare institutions because the care is long-term. Virtual care addresses those issues, but there are definitely some challenges to implementing it broadly. So let's talk through some of those. Cost, reimbursement, and scalability seem to be three primary issues that come up on a regular basis with respect to implementing virtual care. Let's talk about each of those on their own. So let's first talk about cost. Why have healthcare providers been reluctant to invest in new technology solutions?
Yeah, so I mean, it's interesting. So healthcare providers have some scar tissue from technology investments they've made over the years. I think providers have deployed a lot of margin dollars, a lot of capital towards technology. And we're just now seeing some of the returns from, let's say, EHR investments they made 20 years ago. So I think that providers look at technology and implementation skeptically because they should. And so I think when we ask them to consider a new program, then we have to be prepared to say, look, this isn't just cool stuff and it's, let's go do this because the technology allows us to do this. There's a lot of healthcare technology that's really novel and interesting, that's sort of in search of a problem to solve, and that's not going to work. And so instead, I think what we have to do is engage these providers and say, listen, we believe that we're solving for efficiency challenges, that we're solving for capacity challenges, and then most importantly, we think that this is the right care in the right venue that creates the highest clinical and the best clinical outcomes. I mean, if we're not saying that, then we should fold the tent up.
Yeah.
Right? It's not worth doing. And that's true of any, I think, initiative that a provider may consider, technology or other. And so when it comes to the cost, I mean, what's interesting is that, yes, we've seen a decline in technology cost over time. 20 years ago, 15 years ago, remote patient management and telehealth was prohibitively expensive because the devices were expensive. The stuff was expensive.
Right.
So that's not true anymore. But it's really not the technology cost in the form of hardware or software that's prohibitive. It's that what we're asking providers to do is consider a new, kind of almost a new venue of care. So if you think about some of the big telehealth or RPM implementations in the country, there's a call center of nurses that are providing care to patients virtually. And so when you think about capacity, what technology, after it's implemented, has to do is create kind of acceptable thresholds of, let's say, like a nurse-to-patient ratio. And it has to be superior to what you can have in in-person visits. We can deploy home health care and have a certain nurse-to-patient ratio that has in-person hands-on care that allows for a different level of assessment and can, in certain cases, be superior.
Right.
But we're constrained by the number of patients a nurse can take care of in a home health context. And so when we think about these remote settings and virtual care kind of broadly, there has to be this yield. Like, that's what technology should do for us, is allow us to say, because of the predictive nature of what this data can tell us, then we can sort of rank and stack our patients based on risk, not based on a schedule, not based on a rounding pattern, but by risk, so that we know we're engaging with the right patient who needs us the most at exactly the right time. And it's that efficiency that really drives down cost.
Absolutely. And I feel like the other side of that coin is reimbursement. So let's talk about that. Can you talk about any recent changes you're seeing now from a reimbursement standpoint that support technology solutions being used?
Yeah, sure. I mean, there have been several. And some of them, I think, have been made permanent by COVID-19.
Yeah,
And
yep.
I mean, I think directionally, I think they're all correct. What's interesting about reimbursement, so there's kind of two categories of reimbursement changes that we've seen. There's the kind of broad expansion of the hospital at home programs, which have a really specific use case.
Right.
And then there are some new reimbursement codes to incentivize physicians and other providers to really kind of, effectively be reimbursed for the time that they use to provide this virtual care for their patients. And the way I kind of see this is that most remote patient management is about risk mitigation for kind of long-term chronically ill patients. And so to me, I think about these reimbursement codes as a way to push the boat off the dock. So this is CMS giving us a push in the right direction. But eventually we're going to look at these things and say, if what we're really able to do is bend the cost curve because we're intervening earlier and we're preventing the really expensive side of chronic care. So I mean, like, why are chronic illnesses expensive? It's not because the drugs used to treat the most common chronic illnesses are expensive. Diabetes is a good example. Insulin is not expensive. But diabetes becomes expensive when you have an exacerbation that leads to a hospitalization.
Yes.
And so over time, if we can engage and manage these patients and improve their lives, and by improving their lives, I mean in large part keep them out of the hospital, then we can drive costs out of the system. And it's that bend of the cost curve that, from my point of view, is much more compelling than the reimbursement codes. I'm glad for the reimbursement codes because they sort of lit the fuse.
Yes.
And I think directionally where the fuse takes us is right. But I do think that the risk mitigation, the cost containment around kind of the bigger problem of chronic illness is much, much more compelling.
I agree completely. Lastly, scalability. Can you talk about the challenges there with respect to both providers and patients?
Absolutely. So, I mean, it's completely essential. And I remember being at HIMSS about 10 years ago, and I was presenting a remote patient management use case on a panel with a physician from a health system in Michigan. And we had launched this big program. It was home health centric, and it was we had taken care of about 3,000 patients with RPM and various tools, and our clinical outcomes were outstanding. And the physician gave essentially the same clinical results that we gave. The only problem was they had 3 physicians and a dozen nurses assigned to this project, and the number of patients involved in their study was just under 100.
Oh my!
Over a 2-year period. And so they had the worst possible outcome, which is that they had wildly effective clinical outcomes with wildly ineffective financial outcomes. And they basically said, look, this is the greatest thing since sliced bread. We just can't afford it. How could anybody possibly afford it? And so scalability is interesting. I think a lot of times in med tech or the med device case, we think of scalability as a technological problem.
Right. Can
we develop stuff that can be used kind of by broad populations and at scale? We are well past solving that problem. The tech aspect of RPM or telehealth is operating at scale in plenty of places around the planet. Like we can check that box. The question is, from a program design standpoint, can it scale? And so that has a lot to do with patient inclusion criteria, like who are we trying to provide remote care for and why? So are we crystal clear on those things? And then how are we setting up the clinical intervention components so that the nurses and physicians and other care providers are always operating at the top of their license and always providing care to the most urgent, most needed patients at exactly the right point in time. So until and unless you can solve for those problems, then you see programs that do, and I think universally do, have really strong clinical outcomes, but they're just size constricted. And so so how can technology help? So where technology can help is by having solutions that are easier to adopt by patients and that offer kind of cleaner and more predictive data to the clinical team at exactly the right time. And so what that means is the technology needs to accumulate data that's novel and interesting, and then use data science and machine learning to take that data and translate it into a prediction about the direction a person's health is headed, so that that the care provider can identify those patients at risk and intervene sooner. So those things are essential. Just providing data to nurses or doctors virtually is not terribly helpful.
No, not at all. Excellent. Well, thank you so much. I really appreciate your insight, as always. And we thank you for joining us today.
It's my pleasure. Thanks for having me.